Greetings from Vancouver. Okay, let me see. Okay. That was a pleasure listening to Dr. Coe's talk just now, and I hope that we can kind of expand upon that to some extent. I'm a psychiatrist out here at University of British Columbia, out here in Vancouver, and I've known Michael for many years. We did some education work out in China a number of years back. So I was asked to talk about refractory depression, to talk about, chronic mood disorder. And as a psychiatrist, what I would do as steps beyond, say, the usual psychotherapy and medications, and of course, the modifications, as Dr. Coe mentioned. Now, for today's talk, I want to echo Dr. Coe in the sense that, what I'll be talking about are options, right? About options around much more severe psychiatric disorders, and so that you as individuals who are watching this talk can have an idea of the lay of the land about what we can do currently, and also in the future, some of the thoughts and some of the medication and treatment options that you might hear in the news and be aware of. Just a little bit about me. I work out at UBC Hospital mainly, although I spend some time at Vancouver General Hospital and other places as well. I'm a neuropsychiatrist, which means that my work consists of organic disorders, for example, brain injury cases or seizure disorders, Parkinson's, Huntington's, as well as psychosomatic type disorders as well, individuals who have psychiatric disorders, but more functional disorders like paralysis and seizures that might not be due to actual brain injury or epilepsy. And I also manage the neurostimulation program and some new work that we're doing these days with ketamine and the psychedelic type agents as well. So we'll talk a little bit about that as part of this presentation. All right, so quick overview. What does it mean to have treatment refractory depression? We'll talk a bit about medications, psychotherapy, and what are the thresholds above which some individuals might be described as being refractory and unable to treat the depressive illness. We'll talk about neurostimulation treatments. We'll talk a little bit about the psychedelic type drugs and ketamine, and even a little bit about neurosurgery, and then, of course, Q&A later on this afternoon. All right, so first of all, before we can talk about, treatments of mood disorders beyond the standard treatments, we have to think about the smaller portion of individuals who have depressive disorder that cannot be treated by the typical means. So remember that not all sadness is major depressive disorder, that a comprehensive assessment is, of course, necessary because mood disorders are subjective emotional states. They change, they can fluctuate over the course of time and even during the course of a day. And when we talk about major depressive disorder in the psychiatry world, we're actually talking about a syndrome, right, which consists of what are called neurovegetative features. Sleep, appetite, weight changes, energy changes, cognitive changes are all part and parcel of that diagnosis. And, it's obviously important, as Dr. Perret said earlier, Dr. Coe talked about as well, that we talk about the human being as a in the big picture. We are biological, psychological, we have social elements, and of course, a spiritual model, which we're open to talk about here. And I think medicine in general is becoming more and more aware of the importance of this dimension to all of us. When a person is depressed, there are, of course, differential diagnoses, right? There's something called dysthymia, that is low mood, but not quite hitting the major depressive disorder elements with, for example, suicidal thoughts and such. There is, of course, bipolar disorder, where individuals will swing between sadness and excessive energy and elevated mood. There are personality disorders. These are when individuals utilize defense mechanisms that might be not totally useful for what they're trying to achieve in life. And then finally, we got to think about comorbidities every time we think about low mood. Substance use, organic pathology, for example, dementias and seizure disorders and such, which can affect mood, sleep disorders, anxiety, obsessive compulsive. There are a whole host of potential conditions. Now, when it comes to what is adequate treatment for major depression, There's no clear consensus. As Dr. Coe mentioned, there are all these very important elements of diet, exercise, sleep, not smoking, not using alcohol, not using substances. But then the steps beyond that then, of course, is to talk about antidepressants and psychotherapy as well. Adequate treatment in the psychiatry world when it comes to antidepressants typically means that there's an adequate dose of an antidepressant, adequate duration, usually about 8 weeks at least, and of course, good adherence. It's very easy to forget taking the medications as prescribed on a regular basis. And the common definition what we use when it comes to the hospital definition of adequate trial is that there are 2 good trials of antidepressants of different classes potentially, and we'll talk a little bit about the technicalities and such, but for a general population might not be as important, plus 1 adjunct medication. I'll talk about what that means. And then, of course, when it comes to psychotherapy, it really depends on what form of psychotherapy, CBT, IPT, for example, whether proper technique was utilized, and then, of course, number and frequency of follow-ups and treatments with the therapist. Now, whenever I talk about treatment, especially when we go beyond, the standard treatments, it's important to differentiate treatment response and treatment remission. Response basically means that the person's mood disorder is better by about 50% relative to some of the scores and the screens that we use. I see that Dr. Coe mentioned the Montgomery-Åsberg, the MADRS, M-E-D-R-S, but there are a host of other scores and screens that you might see or your family physician, might have in their office. And then remission is what we're really after, right? Remission is when the person's mood state goes to a level which is considered normal, and most importantly, the level of functioning when it comes to relationships, when it comes to work, okay, and day-to-day performance is normal. And these are usually more absolute thresholds using these kinds of screens with specific scores. In psychiatry, we of course try to objectify these very subjective experiences, right? Emotions are subjective in nature, but we try to put some numbers so that we can follow patients along. But ultimately, the goal is good quality of life and functional ability. As the old psychoanalysts used to say, right? It's important to love, to work, to play. And if we can achieve those things in adequate quantities and qualities, then I think we would have achieved a very important part of the basics of life beyond, or at least the basics of life without talking about the spirituality elements. Okay, how common is refractory depression? If we look at all the individuals complaining of depression going into family doctor's office, unfortunately, about 12 to 20% of patients could end up being refractory to treatment, with medications and psychotherapy. And here's a study, if you're interested, in the more academic side, a review of clinical, economic, and societal burden of treatment refractory depression, more than 59,000 patients. And they found that, of this 12 to 20% of individuals, almost 20% of patients had suicide attempts, average 4 previous depressive episodes, 5 unsuccessful medication trials. So the population I'm aiming at as a psychiatrist in the hospital would be this population, right? The ones who are very refractory. And you can imagine how much societal cost this would be. We're talking about billions of dollars of loss potential in terms of work, for example. Now, if we talk about medication treatment for depression, I just want to throw this out there. There's no need to go into this in any great detail, but basically these are the guidelines for the medications we might try these days. These are Canadian guidelines published in 2016, but really not too much has changed since that time. And you can basically see first line, second line, and third line antidepressant medications of all kinds of classes, right? You've probably heard of terms like SSRI, SNRI, adrenergic agonists, etc. We won't go into that in detail, but this is what the psychiatrist, family doctor would look at and say, okay, let's choose one of these agents, and these are the kinds of dose ranges that we might use. And remember, a good therapeutic trial would be an adequate dose for at least, I would say, 8 weeks trial. And then there are adjunct medications. So sometimes the antidepressants themselves are not working, we might, and the person is still in severe distress, we might have to add a secondary type agent. And these medications basically improve energy level, or they augment, they improve the mood state beyond what the antidepressant might be capable of. And again, based on evidence, level 1, 2, 3 type evidence, and the levels are based on, whether there's presence in the studies of placebo-controlled trials or not. We can look at different kinds of medications. These are often classed as antipsychotic medications, but they are used in mood disorder treatment, first, second, third, okay, and then experimental type treatments that are available as well. And as for psychological treatments, now being a psychiatrist, and I'm talking about severe refractory depression, of course, let's not forget that psychology and psychiatry, the medications and the talk therapy, they go hand in hand. And in the CanMat guidelines, they actually do include CBT, IPT, behavioral activation, mindfulness type therapies as well. Okay, it's really hard. I mean, for those of you who might be therapists out there, I think you'll appreciate that it's very hard to get data, to get good data on psychological treatments, whereas it's a lot. I suppose it's a different level of evidence when we talk about medications and being able to do it blinded. So what happens then if we go, or patients are so severe that they require to go beyond medications and psychotherapy? The first one I want to quickly talk about, and I'm sure you've heard over the years, will be electroconvulsive therapy. Okay, here are a couple of scenes from One Flew Over the Cuckoo's Nest from 1975. In North America and much of the Western world, a lot of times when we talk about ECT, people think about these images and how brutal it is. Now realize that by 1975, ECT didn't even look like this anymore. This book was based on a story from the 1950s and 60s before they used generalized anesthesia. These days, ECT is actually quite unimpressive if you were to see it in real life. Basically, anesthesiologists will put the person to sleep in a state of general anesthesia. We have these paddles, which have the electrodes placed on the scalp, and the machine basically delivers an electrical charge. And for about 30 seconds, the person will have a seizure, but you won't really see much of a seizure, maybe some finger movements or hand movements or feet movements, facial grimacing. And then we measure the EEG on the machine, and basically we know when the seizure is over. And then usually within 5 minutes after the seizure ends, the person wakes up. And that's basically how it looks. Literally, it's a 15-minute procedure these days. Now, this is a very old type of therapy, you can imagine, right? It's a well-established procedure. It started in 1938. And people have been using it here in North America since the 1940s. It's very safe. The mortality, if you were to look at it, is 2 in 100,000. But remember that we use this only in the most severe of treatment refractory depression cases. We don't use it with everyone. So that risk is lower than the risk of anesthesia for general surgery. And it is still the gold standard when it comes to treatment refractory depression. So, if you hear of family or friends or individuals who might be suffering for depression, usually for years, and the doctor suggests ECT, this is very typical, and it's still the gold standard in terms of being able to help individuals out more than medications and other treatments. So for severe depressions where there's high risk of suicide, where the person's not eating, losing weight, even during pregnancy, it's relatively safe. There are caveats and complexities there, but it's worth thinking of that. In acute mania, sometimes when a person, they don't sleep for days on end or extremely psychotic and potentially aggressive. And then there are all these other conditions that we can use ECT for. ECT is not uncommon. Now, this is old data from back in 2005, 2006, but within Canada, we do 14 to 16,000 ECT treatments among the hospitals every year, just to give you an idea. Every Monday, Wednesday, and Friday here in Vancouver, we do about 20 a day, okay? Again, just to give you context of how frequently this is done. Side effects for ECT, of course, would include some pain, but we do need the muscle relaxants for the anesthesia. It's done with general anesthesia, so there's always risk for that. Cardiovascular risk factors, memory and concentration are the most important things that people do complain about after a number of ECT treatments. And it's important to recognize that there's no brain damage. I've been doing it for 25 years or more, and some patients have had hundreds of ECTs. And, when you do brain scans afterwards and such, you don't see anomalies there. How does ECT work? Actually, we're not exactly sure. And, that's not all that comforting for a treatment since the 1930s, right? But in a way, it's what Dr. Perret talked about. Psychiatric disorders are extremely complex disorders. And as you heard from Dr. Coe, there are all kinds of mechanisms that could underline how that works. ECT will change the brain activity. It will decrease the metabolism in certain parts of the brain. This is the back of the brain, this front of the brain. It tends to slow down the frontal areas of the brain, which are important areas for how to where moods are processed, for example. It changes the neurotransmitter reorganization. It up and down regulates various chemicals. Okay, and I'll just throw a couple out here. For example, dopamine up and down regulation in different animal models. Glutamate and GABA. We talk about serotonin, we talk about dopamine a lot, but you know what? In the brain, the most important neurotransmitters are actually GABA and glutamate. Those are the primary excitatory and inhibitory neurotransmitters that we need to talk about, and which psychiatric science research is going down the road towards more of. We can see neural network functional connectivity changes, right? The brain is not just one thing. We as individuals, who we think we are, and our consciousness is not just one thing. It is a melding of multiple billions of neurons and support tissues and interconnections that we have in our brain. So at any one time, our brain consists of multiple areas of activity, whether it's somatomotor control, like me moving my hands, or me looking at the screen right now, my visual area, or my attention areas. It's all of that that makes us who we are. And these are interconnected with all these fibers, which by modern technology and MRI and functional connectivity studies, we are able to map out these days. And then, of course, there's the hypothalamic pituitary adrenal axis. Dr. Coe talked about the cortisol and the peaks and dips of the variation, the diurnal daily variation that we see. ECT will change that pattern as well to a more normal pattern where there's not so much cortisol secretion. Now, the usual course of ECT is 2 to 3 weeks. Total 8 to 12 treatments for the index course. So a person will do this usually in hospital 2 or 3 times a week. And then for some people, about 20% of people's of patients, they might need a maintenance course. So once a week or once a month kind of treatments. And these are for individuals who have found usefulness in ECT, but yet medications and other treatments don't seem to be working well. Secondly, we can talk about transcranial magnetic stimulation. You've probably heard about this in the news because many provinces now are trying to get this offered as part of their public service. TMS utilizes what we do with our cell phones all the time, right? We put our cell phones often on a wireless charger. The reason why that works is that magnetism can induce electrical activity inside the brain. And this is what is being done. You've got a magnetic coil put close to the surface of the head, and this is the machine that sends very large electrical impulses that converts to magnetism, and then inside the brain is where it stimulates the electrical activity. Typically, only the top 2 to 4 centimeters of the brain cortex is stimulated by this technology, by the magnetic field. And typically, an outpatient procedure, this is done basically every day for about a month. The person comes into the office for 20 to 45 minutes each time. There's no seizure, no anesthesia, not like ECT, and minimal side effects. It can irritate the brain because the magnetic pulse is strong, and it can be a bit loud, so people will need to put in some earplugs, but there's very low potential for triggering seizures or anything like that. And because it doesn't reach deeper in the brain structure, it's, it's, to be honest, not as strong as the ECT, right? The response rate compared to about 70% with ECT is maybe down around 50 to 60%, still very, very good, and remission about 20 to 30%. Typically, they do this one treatment per day, Monday to Friday, for about 4 to 6 weeks, and then you taper it down thereafter, to hopefully to not require it anymore. And it's possibly more longer lasting than ECT over 6 months. Some people have suggested that potential, but the person still needs to be on antidepressants and psychological work and the usual treatments, even with TMS. There's a lot of research going in this area, and just to throw out some examples as to why. So for example, we don't know the best frequency and pattern of stimulation, how fast you have to send the impulses for that magnetic field to the human brain. There's this thing called neuronavigation. There's a standard procedure, but now you can merge MRI brain scans with where you put this coil so that we stimulate the right area of the brain. Typically, they try to do in the left front area. And then there are different coil types, okay? Depending on how the coil is structured, that changes the way the magnetic field happens and whether you can focus the magnetic field. The ones that we typically use these days look like this, and they're relatively superficial, but the research into these different types of coils that can reach deeper into the brain would be, forthcoming, new technologies. RTMS has been Health Canada approved since 2013. And private options, private therapies have been doing it for more than a decade. But, certain provinces like Alberta, Saskatchewan, Quebec, some hospitals in Ontario will offer this as well, typically with no cost to the patient. Depends. A lot of them are research protocols still. Next, I think you've probably heard a lot of this in the news in the last few years, and these are the psychedelic type drugs that that's coming down. And I think as Christians we should know this because I think it's I think a good, as a psychiatrist, I think it's a good opportunity to discuss what it means to be human, what it means to have the spiritual component of who we are, including options in treatment in mental health. All right, it's mostly experimental still, or off-label use. And what is a psychedelic? Well, psychedelic qualities basically are three elements. One, they are entactogens. That means that they produce a feeling inside, a sense, a sensation or a feeling that of certain types of emotions. They are empathogens. They change the way we feel connected, oneness, being empathic to not just to basically others around us. And they have an entheogenic component, a God within component. During these states, individuals can actually experience the divine. Now, knowing, of course, we are talking about a substance-induced state, so we're not talking about a religious experience per se, but they do have many of those elements that we typically think about as religious individuals. And there's the potential of these medications over traditional antidepressants because the effect is much faster. Typically 1, 2, 3 treatments can change the mood state very significantly, and also suicidal ideation. So those individuals with very acute suicidal thoughts, within a couple, 2, 3 days, these medications can change it. Now, first, I'm just going to talk about ketamine because this is the one that is quite or much more available these days in Canada and basically around the world. Ketamine is actually an anesthetic medicine. It's been around since the 1970s. The way it works is actually glutamate. Remember I said earlier, right? Not serotonin, not dopamine, glutamate. This is the most direct way of actually influencing the brain with regards to the hardware sense, how we change the brain and plasticity. And it's typically IV administered over 40 minutes. It's a dissociative anesthetic. During the treatment, a person will feel sometimes even a sense of out-of-body experience, the mind will feel different during this state for that hour. And a course of treatment is usually about 4 to 6 sessions over usually 2 or 3 weeks or so. And we exclude individuals who are very depressed but have psychosis, active substance use, and those that we're not really sure about the primary psychiatric diagnosis on, okay? Because ketamine, by the way, is also known as special K on the streets. It is a street drug. So, you know, as we utilize these substances, we've got to be wise about what we're doing with them. The potential effectiveness is more than 50% response over basically 4 to 6 treatments, and very high 30 to 50% remission. You often can achieve a state where the person doesn't feel significantly depressed after about 3 weeks. I've seen that many, many times. The availability of it, however, is that currently it's still rather experimental research, but there are many private clinics that have sprung up. And for example, you can see, you know, this only goes up to 2016. By 2023 now, there are many private clinics. There are many private clinics. I know in Toronto, we have here in Vancouver as well, at least 2. And as for public options, it's still quite limited to small clinics and research projects. Now, beyond ketamine, there are these classic psychedelic medications that you will likely hear about as well down the road. These drugs use serotonin and catecholamine, but they are agonists. They increase the level of these neurotransmitters in the system. You know, the golden age of psychedelic research was back in the 40s to the 1960s, but it got all shut down because of all kinds of issues. And it was basically criminalized in the United States and basically around the world by the 1970s. But there's been a resurgence these days in the use in severe refractory depression since about 2006, especially with medications like psilocybin. And these are the main compounds: psilocybin, ayahuasca, which is a type of chemical that they use in South America. And then there are these MDMA and MDA amphetamine type medications. Now, just to let you know, clearly this is still research, but there are some very interesting papers and research coming down the pipeline that even single treatments with drugs like psilocybin might actually be able to change mood state. And I think the reason why I can do that is because, remember, mood is a subjective state. It is potentially possible to change our psychological outlook very significantly with a certain type of experience that perhaps allows a person to recognize the world and themselves in a very different light. Now, the availability of psychedelics, very limited. Since January 2022, Health Canada does allow authorization in very limited circumstances. And then later this year, there could be FDA approval in the States for the use of MDMA. Sorry about my phone there. Okay, so otherwise, it's research or off-label use only. Now, very quickly then, just literally 2 minutes, let's talk about surgical approaches. Back in the 40s and 50s, there were things like frontal lobotomies and things like that for severe depressive disorder. Now, there are 2 types these days that we should, I think, keep in mind. There are reversible procedures, and then there are irreversible procedures. Extremely rare either way, okay? So it's very unlikely that you're gonna run into cases, you know, in practice or in day-to-day life. Dr. Coe mentioned the vagus nerve. We can directly stimulate the vagus nerve for depression. So it's called the vagal nerve stimulator. Basically, it's like a pacemaker you put on the chest, and it directly stimulates parts of the vagus nerve as it goes down the neck. And this could help in treatment refractory depression when people are also on medications. These are deep brain stimulators, okay? These lines, they basically place electrodes deep inside the brain in areas which are important for mood functioning. Very rare, you know, very rarely used in mood disorders, but potentially useful, and you might run into this situation. And then in terms of irreversible brain surgery in very, very, very severe cases, okay, these are cases where people have tried to commit suicide like 20, 50, 100 times. Individuals who have become so severe with, let's say, OCD that they almost break their necks, okay, with their tics and things like that. This is when, you know, we might utilize these kinds of surgeries. And these areas that you see on these scans here, those are the areas where they go in with a probe to basically cause a lesion in those areas. So very rare situations, unlikely you'll have, we're going to see this kind of expansion of treatment for depression in the days ahead. So conclusion, very quickly then. Medications and psychotherapy remains the mainstay for treatment for severe major depressive disorder. Remember that depression remains incompletely understood, as our previous speaker said, and remains a complex biopsychosocial, spiritual kind of condition. Warning against reductionistic thinking, right? We cannot think of depression as just medicine, as just psychological, right? As just social conditions. There are going to be different people with different needs, and we need to be able to understand individuals based on their nuances. And then when it comes to treatment beyond the medications and psychological work, this is the overview that I gave, right? ECT, RTMS, these are the neurostimulation treatments broadly available, ketamine IV treatment, psychedelic treatments in research down the line. And I think very interesting from a spiritual, if I were a pastor, I'd be very fascinated by this area. And then of course, surgical options, very rare, but you might see stuff that. Okay, and I'm obviously happy to answer any questions and comments down the road when it's time. Thanks, everyone.